So, hi, I'm Jen Burzawa. I'm a gynecologic, as Matt said, I'm a gynecologic oncologist who joined ValN about a year and a half ago. I came from MD Anderson Cancer Center where I did my training and then was faculty for about 7 years. And my appointment here is joint at ValN and at the University of Washington at Montlake. And I've joined a great group, as most of you know, Dr. Ron Swenson, who's been here for quite some time. And then shortly prior to me starting, our physician assistant, Mara Barrios, joined as well. So the objectives that I listed for today are some pretty broad objectives. I think I was a little eager trying to get through all of these, but I thought that they would be pretty relevant to primary care and questions that we kind of see come up all the time, even in our oncology-based practice. So I'm going to focus a lot of the talk about HPV vaccination and kind of current indications and questions that often come up on that. I need to enlist primary care help to get patients vaccinated. And I also wanted to discuss some of the kind of current indications for pap smear and some changes that have happened recently, as well as just a brief overview of management of abnormalities. And then briefly kind of just skim over management and diagnosis of vulvar and vaginal dysplasia. So HPV, as we all know, is highly prevalent in the US and worldwide. And like a large number of patients, up to 40% of patients, become infected within 3 years of onset within 3 years of their sexual debut. And it's fairly ubiquitous in our population. The most high risk or pathogenic types of HPV are 16 and 18, which are responsible for 70% of cervical cancers worldwide. And the other high risk types, non-16, non-18, account for an additional 20%. So just with those genotypes, it's over 90% of all cervical cancer. 16 and 18 are also the cause of 90% of anal cancers, as well as a significant proportion of oropharyngeal, cervical, vulvar, vaginal, and penile cancer. And then 6 and 11 cause approximately 90% of anogenital warts. So this is, HPV is a really big problem in medical care. And although it first gained attention with relevant to cervical cancer, I think the important thing to know is that there's a huge burden to our healthcare system from cervical precancer, as well as other anogenital cancers and oropharyngeal cancer. So the thing to highlight, and that I often talk to patients about, is that when I'm seeing patients, most of the patients have already been affected by an HPV associated disease by nature of them coming to my practice. And they often have questions about kind of what the vaccine does and is it applicable to them. So the thing to highlight is that the HPV vaccine is a prophylactic vaccine. So it's meant to prevent acquisition of the virus upon exposure, and is not felt to be a therapeutic vaccine for somebody who's already acquired the infection. As you can see, I've listed here the long list of the specific FDA-approved indications for the current 9-valent Gardasil vaccine, or Gardasil 9. I'm not going to read them all out to you because it's quite lengthy and also pretty impressive at all the cancerous and precancerous, as well as some benign conditions that this vaccine could be helpful for. So to date, there's been a total of 3 different vaccines that have received FDA approval in the United States. The bivalent vaccine, which was just for the high-risk type 16 and 18, the quadrivalent vaccine, and then the nonavalent vaccine, which is against the 2 types that cause the most common types of genital warts, 16 and 18, as well as the other high-risk HPV types. And as of 2017, only the nonavalent vaccine is available in the United States. So that's the only one that you can give. It has been shown to significantly decrease the incidence of squamous and glandular dysplasia and carcinoma in situ of the cervix, vulva, vagina, and anus. And immunity initially was thought to persist for at least 5 years, but more recent studies have shown that it may actually persist for at least 10 years after vaccination, which is fabulous. Wanted to talk a little bit about the efficacy. So, the HPV vaccine is really a cancer vaccine. It's given to prevent the onset of cancer. And I think that's what we really need to stress to our patients. Since it's been initiated, there's been a 98% reduction in the risk of CIN2, including the procedures that are required in treatments, 95% in the reduction of any grade vulvar and vaginal disease, and 100% reduction in high-risk vulvar and vaginal disease. So quite effective. And you'll see, again, this is in HPV naive women. I wanted to talk about the vaccine schedule. So again, this is just relevant to the Gardasil 9 vaccine because that's the only one that's currently available in the United States. And the dosing schedule does differ a little bit for depending on the age at which it's administered. So the recommendation, just to be clear, is that people are vaccinated from ideally at age 11 to 12 and can be vaccinated as early as age 9. The most important thing is that you want to vaccinate before the onset of sexual activity. There initially was a catch-up period from age 13 to 26 that was recommended, and then the FDA just approved up to age 45, and we'll talk about that a little bit more in a few minutes. So the reason that the dosing schedule is a little bit different for 14 years or younger or 15 and older is based on the immune reaction how immunogenic the vaccine is dependent on age. So the younger you are when you get it, the better the response that you have to the HPV vaccine, regardless of whether or not you're HPV naive or not. So for those less than 15 years of age, it's 2 doses that should be given at 0 and then 6 to 12 months. And I just have a little bit, in there about what to do if the schedule gets off. And for those 15 years or older, it's 3 doses. And there's the dosing schedule. I won't read it to you exactly. As I kind of alluded to earlier, the FDA in the last few years approved, actually probably last year. Yeah. For up to age 45, so approved vaccination for up to age 45. Although when you read American College of OBGYN and ACIP about their recommendations for whether or not people really are getting vaccinated age 26 to 45, there's a little bit more wiggle room on this. In the United States, and so insurance is not always covering this. In the United States, it tends to not be a resource, like limited resource situation, but certainly in other countries, they're needing to decide about, where can you get the most bang for your buck. And it seems that vaccinating women in this age range or males in this age range has a little bit less effectiveness. For one, the vaccine doesn't generate quite as much of an immune response. And 2, you're much, after the onset of 3 years after the onset of your sexual debut, you're also much less likely to be HPV naive. Now, that doesn't mean that you've been exposed to all HPV types, which is kind of the benefit of the vaccine. So I think in those situations, it requires a little bit more of a detailed conversation with your patients about the potential benefits to it, especially if patients are needing to pay out of pocket for this. That being said, I missed the vaccine when it first came out based on my age, and I definitely will be getting it now. So some of this, specific things that are called out in their practice advisory is somebody who's unexposed or whose intimacy situation has changed, has a new partner, should consider vaccination if they've not been previously sexually active. And in older women where it's less likely, that they recommend just continued cervical cancer screening as has been previously recommended. So is the vaccine safe? I think, there was a lot of concern about this when it first came out. And overall, the answer is yes, that the HPV vaccine does seem to be very safe. The studies that were performed are on multiple tens of thousands of patients between all 3 vaccines, and in this country and other countries. And the most common side effects that you see from the vaccine are those that you see from other vaccines. It is made from a yeast-based derivative, so that would be the only thing, the absolute contraindication if somebody had an intolerance to yeast. So again, this is just a little bit about efficacy, that, that over 5-year protection for HPV 16 and 18, and specifically with regards to CIN2+. And I wanted to highlight, kind of as I alluded to before, that it is not clearly been shown to be effective in HPV exposed. So you already have HPV, not necessarily an indication to give it. That being said, if patients have had HPV and then cleared the HPV, it seems that vaccinating them can actually boost their antibody titers and provide greater protection, which is part of the reason why the indication got approved to age 45. So, vaccine uptake. So I think, as most people know, it has not been great in the United States. This is a 2015 study that showed, decent at getting 1 dose in, 63 and 50% for females and males, and much lower for 3 doses. And this is back when, 3 doses were recommended for that age range. But in countries like Australia, UK, and Denmark, where there's been a national vaccination program, or it's part of their school required vaccines, the uptake has been much greater, and they've seen a significant drop in their HPV associated diseases. So kind of what are some of the concerns? We already talked about the safety of the vaccine. I think one of the other concerns that was popular in the media, especially when these vaccines first came out, was concern about sexual disinhibition. So there's been several studies done to follow up on this that have actually shown that there's been no increase in risky sexual behavior. And this is based on the need, like visits for pregnancy testing, STD testing, or contraception counseling. There does not seem to be any proof that this is actually happening. And again, I really the way I try to talk to my patients about it is that this is a cancer vaccine. This is literally a vaccine that can prevent cancer. And all the more reason why we should be doing it. And not just one cancer, but many cancers. And just to be clear, it is recommended for males for the same age range that I discussed already. Are there any questions that have come up, Laura? I can't see that at the same time, so.
No, we don't have questions yet.
Okay.
We usually just wait till the end.
Okay, perfect.
Thank you.
So I wanted to go through a couple of case scenarios. So we have a 27-year-old woman who presents for a well woman exam. She has been previously sexually active, but is not currently in a committed relationship. She's never had an abnormal HPV co-test or pap smear, and she inquires about the HPV vaccine. So how should we counsel this patient? So she's kind of outside of the kind of recommended 13 to 26 age range for catch-up vaccination. And it presumably has already been HPV exposed based on her sexual activity. I think it's still reasonable to offer this patient vaccination, and also reasonable to counsel her about the decreased effectiveness that it might have in somebody who's already HPV exposed. But if her insurance can cover it and she can afford it, there's little harm to be done in this situation. Case scenario 2, so we have a 40-year-old woman who was previously vaccinated with the quadrivalent vaccine and is wondering if she should be revaccinated with the monovalent vaccine. So most recommendations are that revaccination with the monovalent vaccine is not required for somebody who previously completed their doses of the quadrivalent vaccine. The small percentage of increased protection that you get from the monovalent vaccine, it does not seem to be an indication to revaccinate people. Case scenario 3, we have a 30-year-old woman who received her first 2 doses of the monovalent vaccine 3 years ago. So to be clear, this is somebody who should have gotten 3 doses. Question is, does she need to restart the series again? And does she need the 3rd dose? So no, the recommendations are that if does not need to be restarted. so that you can just go ahead and continue with what has been prescribed, like with the, if you've missed one dose, to give the third dose, if you missed 2 doses, to give the last 2 doses, regardless of how much time has elapsed. It is recommended that that you try to stick with the same vaccine. So, you know, if somebody got, unfortunately, the other 2 vaccines, the bivalent and the quadrivalent vaccine, are no longer available in the United States. So I think it would be reasonable in that case to give the patient their final dose using the monovalent vaccine. And yes, it does seem like there is a high level of immunity that's acquired just after 2 doses, even in patients older than 15 years, but it is still recommended for that age group to go ahead and receive the 3rd dose. That recommendation may change over time as we get more information. And then case number 4, 27-year-old woman undergoes a leap for CIN3. She has never been vaccinated. Should she receive the vaccine? Again, a little bit of a gray zone. There's been some smaller studies that actually showed that patients who have had to undergo an excisional surgical procedure for CIN2 plus may gain some increased immunity when they're vaccinated right around the time of surgery. And that's thought to be somehow related to the surgical site and the virus interaction at the surgical site. So I think that that would be reasonable to do. And certainly patients in this situation would be an excellent candidate for a clinical trial if one should be available. There is a clinical trial available at the University of Washington now, the VIVA trial, that patients can be referred to regardless of where they receive their care. That's actually vaccinating women with who are presumably HPV positive with the vaccine in order to try to prevent further vulvar and vaginal dysplasia. And then the key point I have to make as a GYN oncologist is that, one, vaccinate, vaccinate, vaccinate. I think this is like a huge opportunity to reduce a lot of impact of cancer and pre-cancer. And that currently in our country and other countries, the status of HPV vaccination does not impact cervical cancer screening recommendations. So even if you're vaccinated, your screening is still the same. And I don't expect that recommendation to change. And that kind of will lead me into our next topic, which is cervical cancer screening. One other thing I just want to point out is that, even, for most patients who are getting adequate cervical cancer screening, the, cervical cancer is considered a preventable disease for the overwhelming majority of patients. But the precancerous lesions that require invasive and uncomfortable procedures could potentially be avoided by HPV vaccination. And certainly excisional procedures like leaps and cones can have adverse pregnancy outcomes. So increased risk of cervical incompetence, cervical stenosis, and preterm birth and preterm delivery and birth. Even if we are like cervical cancer in the United States is considered a preventable disease, we want to prevent the precancerous lesions as well. Okay. So cervical cancer worldwide is a huge, huge problem. It's felt to be like 99+% positive related to HPV. In the United States, less of a problem. So it's our 3rd most common gynecologic cancer with approximately 12,000 cases diagnosed in the US. And the significant reduction is obviously felt to be related to an adequate screening test with the Pap smears. And most of the cases that are in the US, over 50% are felt to be related to inadequate or absent screening. So lack of appropriate healthcare, whether that's patients lack the resources or not coming in for their regular visits. Worldwide, obviously that's not the same, as not everyone has the access to the same great healthcare that we have here. And it still continues to be quite a large problem. I wanted to just go over briefly some of the recommendations for cervical cancer screening. They are a little bit different depending on which society that you look at. So USPSTF recommends, women aged, so not begin before age 21. So at age 21 to 29, it's screening with cytology alone every 3 years. For 30 to 65, it's every 3 years with cytology alone, every 5 years with high-risk HPV testing alone, or every 5 years with co-testing. And that younger than 21 or over 65, not recommended basically at all. The caveat being with adequate prior screening. And we'll talk about that a little bit. And women who have had a hysterectomy, and we'll talk about that a little bit more. So certain risk factors. So the patients that this might not be applicable to is people who have an increased risk of cervical cancer. So the recommendations are different for somebody with who's immunocompromised from either from medication or from HIV infection, those with in utero exposure to DES, and those with previous treatment for a high-grade precancerous lesion of the cervix. And the follow-up for them is recommended a little bit different. So you can see that we kind of, as time has gone on, we've definitely gotten away from the importance of cytology and are moving towards, I think, HPV testing alone. Although I think the majority of people are still probably doing co-testing in this age cohort. And for younger women, it's cytology alone because of their high rate of HPV positivity and their low rate of having precancerous lesions related to their HPV positivity. Most of the people in this age group are acquiring HPV for the first time, and the vast majority of them are expected to clear the HPV infection without secondary precancerous lesions or cancerous lesions forming. We're also, this is the reproductive age group, so trying to minimize the amount of unnecessary excisional procedures that can adversely impact pregnancy outcomes in women who would otherwise have cleared the virus on their own. American Cancer Society, these are just their recommendations. They are a little bit different. They, I think, stress, so they actually say age 25 to 65. So they say initiate cervical cancer screening at age 25. And their actual primary recommendation is for HPV testing alone. And then that's not available, co-testing can be performed, or cytology alone. So I think the caveat is that cytology is probably the least important thing that we do in the majority of patients. They also talk about in their recommendations here, I'll just point this out, that what they define as adequate negative screening. So for somebody who's 65, who you're considering stopping screening on, it means that they have to have kind of met these criteria. So 2 consecutive negative HPV tests or negative co-test, or 3 negative cytology tests within the past 10 years. And those are in the patients and who you can consider when they reach 65 stopping. So for, a 65-year-old who's presenting to your office who hasn't been in the healthcare system for the last 10 years, it is not appropriate to stop screening her at that point in time. And then obviously for individuals who have a limited life expectancy, cervical cancer and who've had previous normal test cervical cancer screening is not recommended. There is a significant portion of patients that are being diagnosed with cervical cancer at older ages. And I think it's important to make sure that we're not missing this population. The other thing I wanted to talk about, so this is some of the things that we talked about previously, like the recommendations, these kind of at-risk populations. And for those, so for women who've had a hysterectomy, it is recommended that they no longer need to undergo vaginal pap smears at all, unless they have a history of prior, so DES exposure, or a history of prior CIN2 plus or cervical cancer. For the patients that have had a history of CIN2 plus, so have had a previous excisional procedure or an actual cervical cancer diagnosis, it's recommended that they continue screening for, I used to say 20 years, the updated recommendations for 25 years after their initial dysplasia diagnosis because of their risk of other HPV associated lesions such as vaginal dysplasia. So But in the patient who's had a hysterectomy for a fibroid uterus, they do not need pap smears anymore. So these are the recommendations a little bit for somebody who has had a previous HPV associated disease, such as high-grade cervical dysplasia. So they're actually a little bit more frequent. So it's not 5-year intervals, but 3-year intervals for HPV testing or co-testing, and then, triage to management based on their abnormalities. And that it's, actually could consider continuing to surveil them even beyond the 25-year mark. We talked about this briefly before, but I think things to consider as to whether or not it's appropriate to test your patient every 5 years, and certainly to stop screening for somebody who's over 65 years is their adequacy of their prior screening. And history of other HPV associated diseases. And these are just kind of, I'm not going to read them to you specifically, but these are just kind of the outline of what's considered adequate prior screening. Kind of the reminders is that, as you visualize all the external female genitalia as well as the cervix, anything abnormal should always be biopsied regardless of what their screening test shows. So you look at the cervix, there's something abnormal, but they've had a negative HPV test. The answer is still to biopsy it. There recently, in the last couple of months, the ASTCP came out with some guideline changes about the actual management of abnormalities. And so this is quite a lengthy summary document that they have, and it's gotten a little bit more complicated. So basically, it's talking about expedited treatment. So for patients that have certain findings on their pap smear or HPV tests, like actually skipping colposcopy and going straight to excisional procedures. They said that colposcopy can be avoided in certain patients, and that the recommendations are basically not just based on a patient's results, like HPV high-risk positive or not, as far as management of abnormalities, but is more based on their risk, so their prior HPV testing to that. They also, I just want to point out number 4 here, is that excisional treatment is preferred to ablative treatment for high-grade abnormalities, and particularly for adenocarcinoma in situ. I think those are kind of this is where the 3-year intervals for 25 years came up, that we kind of already talked about. But I just wanted to point out that this is here, and it's getting a little bit more complicated as time goes on. So, I want to point out that there is an app for that. This app is great. I think most of us in Gynecologic and Oncology and OBGYN have this app. Unfortunately, it's not free. It's $10, but it's a lifetime subscription to that. So as the management guidelines get updated, your app gets updated. And you can't see in this picture, but there's screening guidelines. So it walks you through like who needs a PAP, and then management guidelines. So, for abnormal PAPs, what do patients need? And I think, if you're ever not sure, you're always welcome to phone your friendly GYN oncologist or OBGYN for help in colposcopy or management, or if you're not sure what's appropriate, we're always happy to see these patients. So next I wanted to kind of transition into talking about vulvar and vaginal dysplasia a little bit. And the first thing I wanted to talk about was whether or not to do a pelvic exam. So in the absence of somebody needing STD screening or pap smear being performed, do patients still require a pelvic exam? And there was a bit of debate about this a couple of years ago when some of these initial kind of recommendations came out, and especially as our screening tests have gone from being annual screening tests to being every 5 years, are patients still needing a pelvic examination? So obviously a pelvic examination should be part of the being performed for anyone who has symptoms concerning for gynecologic pathology. the important statement here is that the decision to perform a pelvic exam should be a shared decision-making decision between the patient and her OBGYN or other gynecologic care provider, including their PCP. And that basically in the absence of screening for cervical cancer or STIs based on a patient's request, that the detection of other diseases is actually fair, like the pelvic exam is not great at detecting these other diseases, especially in asymptomatic women. And so I think in this patient population, it should be a conversation, given that it is an invasive procedure, had amongst patient and provider about who it's appropriate for. Obviously, I'm a gynecologic oncologist and I see a lot of pathology, so I personally think pelvic exams are pretty important. But it's also important to be clear about why you're performing the procedure and what you hope to detect from it. So again, these are some of your high-risk populations. The American College of OB/GYN recommends are undergoing this, and unsurprisingly, we recommend that somebody should still see a gynecologist or their primary care practitioner once a year for routine well woman care to discuss their and specifically to address their OB/GYN care, regardless of whether or not they actually need a pelvic examination. And they specifically call it that a pelvic examination is not required before prescribing contraception. So that being said, what are the other things that we could potentially be looking for in a pelvic exam? So one thing is vaginal dysplasia or VAN. It's actually quite uncommon, vaginal dysplasia. And we think that this is the glandular transformation zone of the cervix is much more susceptible to HPV associated change than the squamous, the pure squamous tissue of the vagina or of the penis, which is why this is much less prevalent. Although the whole gynecologic tract is exposed to the same HPV, why it's less virulent in these tissues. I do want to point out that patients who have had a history of CIN2+ have at least a 7% incidence of developing, who've had a hysterectomy for CIN2+ have at least a 7% chance of developing vaginal dysplasia. And so again, this is why, one, we don't always recommend hysterectomy for patients that have CIN2+ that has been adequately treated with excisional procedures, because it doesn't necessarily get you out of this loop of needing follow-up and colposcopies. And again, this is the patient population that really still needs to have their annual, not their annual, but their routine screening pap smears, because they are at high risk for developing vaginal dysplasia. There is also a high percentage of patients that have one HPV associated lesion, so a previous cervical cancer, that develop vaginal and vulvar dysplasia. And that can happen sequentially or concomitantly. So patients can have all 2 or 3 at the same time. And so taking an adequate history of other HPV associated cancers is pretty important. A very small percentage of vaginal dysplasia, just like cervical dysplasia, would actually, and even less, would actually progress to invasive cancer. And for patients that have high-grade vaginal dysplasia and are managed with an excisional procedure, actually, it's not uncommon to find, depending on what study you read, like a 5 to 30% chance of finding an underlying malignancy at the time of their excisional procedure. So most of these are detected by Pap. If you're doing a speculum exam on somebody who's had a hysterectomy and you see an abnormality, again, biopsy it. Biopsy is always our answer. But for somebody who has an abnormal vaginal Pap, then it's recommended to perform colposcopy with dilute acetic acid and consider luol solution as an adjunct to your regular colposcopy. And that these are the things that are kind of easy to miss and hard to find. Vagina has lots of rugae, and in someone who's had a hysterectomy, it can be very difficult to kind of adequately in the office, even for GYN oncologists, to see all the possible hiding locations for these lesions. So biopsy anything that you see that is abnormal. If you have a high-grade Pap and you can't find anything that's abnormal, that would be a reason to consider referral to an OB/GYN or GYN oncologist with experience to try to find that lesion, or even consider ablation if the lesion can't be found. Management for VAN, low-grade VAN. So the terminology has changed a little bit. It's now, instead of VAN, actually it's a low-grade squamous intraepithelial lesion of the vagina is observation. And for vein 3, it's recommended for either excision, ablation, or topical treatment. And they're really trying to get away from using vein 2 and to recategorize those patients as vein 1 or vein 3. Excision usually is performed vaginally, so with basically a wide local excision of the vaginal lesion. If it's a discrete lesion that can be seen and won't cause too much sexual dysfunction for the patient, but for multifocal lesions or lesions that are difficult to excise, ablation can be considered. Very rarely should an abdominal procedure be needed for vein 3. And kind of last resort would be, to be clear, an ablation is a CO2 ablation, which would typically, but laser ablation, which would be performed in the operating room under anesthesia. And then for patients who aren't a great candidate or have had lots of prior treatments, and you want to try something different, topical application of imiquimod or less commonly 5-FU can be used, although application in the vagina can be very difficult to get it to the appropriate places. These do not come with vaginal applicators. And then what about for patients who have had surveillance? So the ASCCP actually doesn't have any management guidelines for management of vaginal dysplasia. Kind of what I could find online was the recommendation for every 6 months, to undergo clinical exam every 6 months with annual co-testing, and then repeat colposcopy for any HPV positive disease. Honestly, what I've practiced and seen more commonly in my practice and kind of the algorithms that we followed is every 6 months for 2 years with PAP, as well as vaginal colposcopy at the time of PAP, because this is a more difficult disease to treat, and these lesions can persist. They persist a little bit more than the cervical lesions do. And I felt that HPV testing personally is like a little bit less helpful in this patient population because we know that they have HPV, they have vaginal dysplasia. But we know HPV is not as pathogenic to the vaginal tissue as it is to the cervical tissue. So I find it a little bit less helpful about what to do in that situation. But if somebody has a positive HPV test of the vagina, that's going to require colposcopy for further evaluation. And then briefly, I'm out of time. I just wanted to talk about vulvar dysplasia. Again, it's pretty similar. The terminology has changed, but, and it's also fairly rare. But any abnormality, you're supposed to biopsy. And then the management of vulvar dysplasia is also excision preferred, as long as it's in an area that's safe and not going to compromise like sexual function. Ablation or topical treatment are acceptable options for non-surgical candidates or multifocal disease. And I'll stop there.
Okay, we have a few questions. First one being, somebody made a comment, actually, that the UW primary care update in September recommended PAP screening starting at age 25. And I'm not sure if that was made before you were talking about the age for starting screening or not, but if you had any additional.
Yeah, and I mean, I think that's based on the American Cancer Society's recommendations to begin at 25 instead of 21. So I think that's reasonable. I think you can also make a determination 21 versus 25 based on your patient's risk factors.
Okay. Next question, if cytology otherwise negative, plus or minus contesting done, if you see moderate inflammation on the PAP result, does that ever change our management with the next PAP?
I mean, I think, if you're, when I see inflammation on the PAP result, I would be more concerned about vaginitis or cervicitis. So is there, is there something that's causing that inflammation? As opposed to necessarily being worried about whether or not that's related to HPV associated disease. I think the important thing is the patient having symptoms. If there's something you're concerned about, it's always okay to biopsy it. And it's also okay if you're not feeling great about it to bring that patient back and have them have an evaluation and try to include HPV testing when possible there.
Okay. And then back to the question about the age with starting PAPs, somebody also asked, I've heard some people starting PAPs at age 25 instead of 21, and what do you recommend?
Yeah, I mean, I think we tend, as GYN oncologists, tend to follow the American Cancer Society's recommendations. I concur with 25. So, but I think if somebody was 21 and really wanted a PAP, I don't know that I would be denying them their, their request to undergo screening. So.
Okay, great. Well, thank you very much. That's all the questions that have come in.
Thank you.